morning. I'm Jack Stein, Director of the National Center for HIV and Substance Abuse Training based in Arlington, Virginia, and also Chair of the HIV Task Force for the National Association of Social Workers. Together with my colleague and conference co-chair, Dr. Tom Coates, I'd like to welcome you to the 1994 National HIV Frontline Forum video teleconference. Much time and energy have gone into the planning of this landmark event, none of which would be possible without the generous financial support of Burroughs Wellcome Company, and we thank them. Many of you may be familiar with the Frontline Forum regional meetings series conducted over the past several years. As the interest and participation in Frontline has grown, new avenues have been explored to provide the maximum number of HIV Frontline counselors with state-of-the-art information about HIV counseling. This year, we're proud to present this forum coast to coast via satellite to 33 cities in the United States, Puerto Rico, and Canada. From the very beginning, the AIDS epidemic has placed multiple demands on virtually every sector of the healthcare system. As the number of HIV-infected people continues to grow, as the demographics continue to change, and as the treatment options continue to increase, the need to assist clients through the complexities of accessing and receiving HIV treatment becomes greater and greater. As caregivers, we often do not take the time to stop work and to reflect and learn from our experiences. This conference is designed to help us do just that. We have assembled a national faculty consisting of 6 HIV frontline counselors with diverse professional backgrounds including social work, psychology, and nursing. Our national faculty will help set the foundation for a number of key counseling issues presented by HIV/AIDS. And twice today, you will have the chance to ask questions and exchange views with these HIV frontliners. To complete the event, we've also invited local faculty in your own area to facilitate workshops and discussion groups based on the information presented by our national faculty. In this way, we hope you can tailor the issues discussed here to meet those faced within your own community. This event should prove to be an exciting and enriching experience. We look forward to a productive day with you. And now let me turn things over to my co-chair, Dr. Tom Coates, who will introduce our faculty and our first speaker. Tom?
Thanks, Jack. Hello, I'm Dr. Tom Coates. I'm a psychologist in the Department of Medicine at the University of California, San Francisco. My clinical work involves treating many individuals with HIV disease. In addition, I direct the Center for AIDS Prevention Studies, where we investigate strategies to help prevent people from getting infected and to help individuals with HIV to take good care of themselves. To my right is Dr. Robert Remian from New York, Lana Kaopua from Hawaii, Judy Polachek from Washington, D.C., Billy Jones, also from Washington, D.C., Sue Gallego from Texas, and Mark Illiman from San Francisco. Mark, our first presenter, is a family nurse practitioner with considerable clinical experience in a busy HIV practice in San Francisco. HIV treatment is a complicated and ever-changing field. Counselors need to be able to help their clients work with medical providers to be sure that they are getting the best possible treatment. Mark outlines how counselors can help clients to do this, and also how counselors can stay up to date with a rapidly changing field of therapies for HIV and for opportunistic infections. Mark?
Thank you, Tom. I want to discuss how counselors can work successfully with medical health care providers on behalf of their clients facing HIV, and how counselors can help the patient negotiate through the complicated and changing arena of HIV treatment. I think it is important to remember that people are living longer with HIV disease and with a much improved quality of life today compared to just a few years ago. This is partly due to aggressive therapy and prophylaxis for opportunistic infections, to early antiretroviral therapy, and also to patients themselves being aggressive at challenging authority and assuming active responsibility in making decisions about their treatment.
Take a deep breath.
Patients are empowering themselves to learn about their disease and seeking out aggressive treatments and aggressive healthcare providers. This poses a challenge to the healthcare delivery team and to those of us doing primary care in that it forces us to remain current with the constant changes in HIV care. At the same time, however, it gives us the opportunity to work with a very motivated and enlightened group of patients who want to learn about their condition and to become empowered to become an integral member of the healthcare team. The counselor is an integral part of the healthcare delivery team. In order to be effective in counseling patients facing an endless number of issues throughout the course of this disease, You must become empowered to learn about the disease and to work effectively with physicians and other team members. In order to effectively communicate with patients, you must learn the language of HIV disease, the potential complications and opportunistic infections that can occur, the various markers of disease progression, and the standard treatments available, including not only antiretroviral therapy, but prophylactic therapy. You must have a good understanding of the natural history of HIV disease so that you can predict and discuss issues that arise throughout the course of the disease. By networking, it is usually possible to identify a provider or a group of providers in your community who treat a large number of people with HIV disease, both in private practice and in community-based clinics. Contact one such group and spend time in the practice observing patient-provider interactions to become familiar with the issues that arise, the treatments available, the patient's concerns that are discussed, and those issues that arise and are left unaddressed or postponed for the next visit. Even a busy physician can often find the time to teach. You might, however, have more opportunities to ask questions and interact with patients if you find a practice that uses mid-level providers such as nurse practitioners or physician's assistants. Such professionals are often more approachable and willing to address psychosocial issues and to teach the patient about his disease than is a busy physician. To begin, you should have a very short agenda. For instance, the first meeting could feature a physician who would discuss the natural history of HIV disease. The second meeting might focus on current available therapies, and the third meeting could be facilitated by you and could address the psychosocial issues that occur in facing this disease. On the national level, there are a number of organizations and resources available to learn about HIV disease. In your packet of information, you will find a recommended reading list developed by the Positively Aware group in Chicago that contains newsletters, monthly magazines, and textbooks. In addition, the American Social Health Association in Research Triangle Park, North Carolina, is an excellent source of support services, HIV treatment groups, physicians, and counselors. Their hotline runs 24 hours a day at 1-800-342-AIDS. For those of you in rural settings, this might be the first place to look for a local physician or group practice that you can contact. I'd like now to discuss ways that you can help patients access and take advantage of the healthcare delivery system and touch upon a few of the key issues where you, the counselor, can become pivotal in helping the patient integrate all that is happening to him or her, reevaluate what is important, and face each challenge as it comes. If your practice is composed of people with HIV disease, they will undoubtedly be at various points along the spectrum of illness. Let's begin the discussion, however, at the point that someone has learned that he or she is HIV positive and has already wrestled with all of the questions about should I be tested or should I not be tested. Such patients have dealt with the fear of knowing and are now facing new fears, such as the loss of entitlements, job, insurance, friends, residence, and relationship with family. The counselor plays a key role in helping patients conquer their fear of being alone by helping them to open up emotionally. You should acknowledge that being tested was a very difficult step to take, but a very important one in terms of finding out their HIV status and beginning the fight as early as possible. It is often useful to remind patients that they may have been infected for quite some time, and that essentially nothing is different today than it was 6 months ago. The only difference is now that their positive status is known, and they can take the appropriate steps to begin facing the disease by seeking appropriate medical care. The counselor can be pivotal at helping clients in their first steps at accessing the healthcare delivery system. This may include recommending a well-known HIV specialty group, a university clinic, an inner-city clinic, or the best infectious disease specialist in a small rural area. Another toll-free number, 1-800-TRIALS-A, will help identify nearby physicians involved in HIV-related clinical trials. These physicians are usually affiliated with a hospital where many persons with HIV and AIDS are being treated. Establishing a good working relationship with a provider will influence how patients approach their health and the course of treatment. Many patients on Medicaid or Medicare may face even more difficulty in finding physicians willing to treat them. Low-income patients may want to find a physician who accepts patients on a sliding fee scale. Another way to access lower-cost care or treatment is through clinics affiliated with a medical school. Many community clinics offer up-to-date and culturally sensitive care that is affordable or free.
To reduce your risk of any sexually transmitted diseases, you would definitely use a latex condom at all times.
Some of the considerations in helping your client choose a physician or other healthcare provider should include: does the provider make the client feel comfortable? Since the provider will be an important source of support and information, one should feel able to discuss all aspects of HIV with him or her and trust the suggestions that are made for treatment. Find a provider with a similar communication style to the client. Does he or she explain things in language and terms that can be understood? If clients don't understand their condition, they'll be less able to help in their own treatment. Can the client be honest in expressing any questions, fears, or personal issues, such as being gay or bisexual, having a lover besides a spouse, or using drugs? Advise clients to find the provider whom they believe will work with them over the long term. This will be a relationship that continues for the rest of the client's life. Is time allowed to discuss treatment options, drawbacks, and benefits? If the client is interested in pursuing alternative therapies, is the provider supportive? Look for accessible location, transportation, and office hours. Determine if the physician prescribes a combination of antiretrovirals and what drugs he or she prescribes for prophylaxis. Ask if the physician enrolls patients in expanded access programs for experimental therapies. Healthcare providers should supply phone numbers through which they can be reached 24 hours a day. Compare costs for professional fees such as initial and follow-up office visits, required tests, and add-on services. Identify payment terms and limitations on insurance and pharmacy purchases. Make sure that the client's insurance will cover the visits. Recommendations from friends, peer support groups, dentists, gynecologists, counselors at HIV testing sites, local AIDS service organizations, or AIDS hotline numbers are very useful in finding a physician. Other considerations are outlined in a booklet available from the American Medical Association, Choosing Your Physician. You may call 312-464-4443 for a free copy. Choosing a physician is one of the first steps to living with HIV. Once a provider has been identified, you may begin to help the client learn to negotiate treatment. Assertiveness training will be important for many clients. A provider may have a perfect right to suggest a specific test or treatment for the client, and the client has the right to delay or refuse that advice. You can help clients by teaching them negotiating skills and diplomacy so that they can work with their provider in a manner of mutual respect rather than anger, hostility, or alienation. Here are some practical tips in helping the clients make the most of each visit with the provider. The time patients and providers have together during an office visit goes very quickly. Preparation is the key to getting the most out of the appointment. Clients should write down in advance any questions they have. They should bring articles describing new HIV treatments they want to discuss. They should bring a support person, a lover, a spouse, or parent to the appointment. They should take notes during the visit, or better yet, have the support person take notes. This will often eliminate misunderstandings in trying to remember the instructions given hours or days before their application. Clients should bring a written medical autobiography with them during their first visit. This helps record accurate information and lets the physician know that clients are aggressive about health care. This list should include Social Security number, insurance or public assistance ID numbers, insurance authorization phone numbers, pharmacy benefits ID numbers and locations, current and recent medications with strength and daily dose schedule, complementary and alternative therapies, including special diets, supplements, vitamins, and non-drug therapies, allergies or adverse reactions to drugs, names of the client's other physicians or specialists, lists and dates of diseases and infections that they've had, dates and reasons for hospitalizations, dates of procedures such as bronchoscopies, transfusions, ophthalmologic examinations, and CAT scans, dates of HIV antibody tests, dates of AIDS-defining illnesses, and records of immunizations. Counselors can be crucial in helping clients learn to work with healthcare providers to discuss emotional as well as physical concerns. Stress, anxiety, and mood swings are common emotional responses during HIV infection. These may grow from a sense of impending doom, fear of abandonment, and guilt or grief related to friends who are ill who have died from AIDS. The psychological impact of being HIV positive may prompt appetite and sleep problems, mood swings, lowered sex drive, decreased energy, and lack of satisfaction with things that normally bring in enjoyment. Dramatic behavioral changes in our patients can be caused by the emotional response to living every day with HIV. to neurological disorders such as dementia, or to side effects of medications and drug interactions. Psychometric testing by trained therapists can be very useful at sorting out whether these changes are emotionally based or a medical complication of HIV disease itself. Emotional problems may increase with the onset of disease progression, at the time of beginning treatment with antiretroviral therapy, or with the development of physical symptoms. Helping the client to make the physician a partner and friend will allow the interaction to become as comfortable in exploring feelings as it is in exploring treatment options. Encourage the client to become as comfortable talking with the healthcare provider as he or she is in talking with you, the counselor. An early issue that arises once clients learn of their HIV status is to whom and when to disclose this information.
I never told my dad. He just passed away, and I never had a chance to tell him.
Disclosure to friends and family should occur in an appropriate and supportive manner and at a time that is appropriate. Spend a good deal of time working with clients on this issue of disclosure. Help your clients get to a position of confidence that they understand the disease, that they have the best health care available, and that they are emotionally equipped to deal with the diagnosis prior to disclosing. If this is not the case, they will have a very difficult time reassuring loved ones. This is a very complex issue, and many legal as well as ethical issues must be addressed. As I mentioned earlier, aggressive monitoring and medical care for HIV disease can result in fewer opportunistic infections, illnesses that are less severe, a better quality of life while well, a delay before symptoms begin, and a survival advantage after the arrival of advanced illness. Early HIV health care intervention is more than medical treatment, however. It is a way of living and an outlook on life. The counselor assumes a central role with the healthcare provider in focusing the patient on wellness and living with HIV by making positive changes, such as controlling stress, developing coping skills and positive attitude, and building social support. The client's CD4 count, one measure of disease progression, should be known by the clients. They should learn as much as they can about HIV disease to empower themselves to ask the right questions and seek the most aggressive treatments. They should watch for opportunistic infections and learn at which CD4 count to begin prophylaxis. Many of the life-threatening diseases associated with HIV can be prevented today if they are anticipated and therapy is initiated early. Clients should have an annual tuberculosis skin test or a chest x-ray. Clients should take a good daily multivitamin. Daily vitamin supplements are important in people with HIV and important when poor diet or illness may interfere with dietary needs. Clients should maintain a healthful diet. Moreover, a nutritional consult is useful since many foods may not be well absorbed in people with HIV and AIDS. Female clients should have regular OB/GYN exams. Appropriate therapy for recurrent vaginal candidiasis and an annual or semi-annual pap smear is necessary. Clients should be encouraged to stop abusing alcohol and other drugs. Cessation of cigarette smoking is also important. Further deterioration of the immune system has been well documented with these agents. Referral to an appropriate alcohol or drug rehab program may be necessary. Clients should see a dentist 3 times a year. Chronic gingivitis and dental decay are not uncommon with HIV disease. Proper dental hygiene can help eliminate complications. Regular ophthalmologic examinations are important. This is especially critical for clients whose CD4 count is below 100. CMV retinitis, a very common opportunistic infection, may very well occur at this count. Left untreated, CMV retinitis can cause blindness. Have clients consider therapies with AZT, DDI, DDC, and D4T, and ask healthcare providers about the state-of-the-art combination antiviral therapy, what drugs can be combined, and what the current treatment recommendations include. Clients should exercise regularly. Good health requires frequent cardiovascular exercise. This can be as little as 20 minutes 3 times a week on a stationary bike at the gym or a brisk walk. Cardiovascular exercise not only helps with circulation, but often improves sleep disorders and reduces stress. Every day, HIV-positive people must make decisions of enormous importance without any clear proof about the best path to take. Many answers to these questions are unclear, even to the best trained healthcare professional. The process of dealing with the diagnosis of HIV requires the ability to recognize, communicate, and release emotion, perhaps the most powerful advice any person coping with a chronic disease can follow. The counselor should be aware that the stages of acceptance are very similar to those in the grief process. When clients become angry, help them focus their anger on the appropriate source. When clients become depressed, you can be instrumental in assessing the depression and working with the healthcare provider and helping to manage the depression with or without antidepressant medications. When clients finally accept their illness, it is imperative that you help prevent this from turning into resignation, where the client may say to you, "I don't want to do anything." Work with clients living with HIV to fight the disease. In summary, your goal as a counselor in helping people in the fight with HIV is to empower yourself to learn about the disease and to help your clients integrate all that will occur in their medical care with your psychosocial assistance and intervention. Many of your clients may not be used to working with their providers in the ways I have suggested, and many of these suggestions may not be possible in all settings. Helping your clients to learn even a few of these steps will give them more control over their disease, and that control will be invaluable in their fight to survive. Thank you.
Mark, thanks a lot for a very nice presentation. You covered a lot of complex material and I think gave us a lot of concrete points to think about. The field of treating people with HIV disease is a very complex one, and it changes as people progress through the disease. I'm wondering if you could begin by just reviewing for us briefly the major landmarks at which those treatment decisions need to be made to help the counselor be aware of that.
Mm-hmm. Yeah, I think there are two issues. One is antiretrovirals, and the other is prophylaxis for opportunistic infections. And I think people have to be real clear that there is a difference between the two. I think as time goes and as we learn more and more about disease, it becomes less clear when to start antiretroviral therapy. I think that was a big lesson that came out of Berlin at the AIDS conference, is that we're not sure anymore when to start AZT, for instance, or DDI or DDC. And I think it's taught us that these antiretrovirals work, and they are appropriate, they work. We're using them in all of our patients daily. But the question is, when do you start the therapy? And I think one thing that we're doing, and I think it's good, and I think more physicians are learning to actually work with patients, to listen to patients, to examine the patient, and look for clues of disease progression. I think if the physician or the practitioner senses that there's been a change in the patient's condition, if there's appearance of candida in the mouth, certain skin rashes that may appear, herpes zoster, if a patient comes in and says, "I'm more symptomatic, I don't feel as well as I did, I'm getting some fevers now and then, I've got some night sweats," those are all indications that there are changes, that the patient may not be asymptomatic any longer, and that might be an indication to start antiviral therapy, even if their T cells are, say, 500. I think the standard still is that you start an antiviral around 500 CD4 cells, but we can postpone that, and we often do in a lot of patients who are down around 300 to 400 if they're asymptomatic over a long period of time. So that's probably one of the biggest milestones. In following the CD4 count, once it drops to about 200 or 14% of the total, you start to worry about pneumocystis. That's one of the first serious life-threatening opportunistic infections that can occur.
So there really is a difference between the decision to take antivirals and the decision to initiate prophylaxis. And
Right.
It's helpful to keep that distinction in mind
Right.
when counseling clients or helping clients.
Just to emphasize a point, because I believe very much as you do, Mark, in the importance of the doctor-patient relationship in ongoing care. And I think it's why what you talked about initiation of antivirals, I think, especially since Berlin, it's much more up in the air and less of an automatic kind of standard of treatment thing. And what's important is that there probably is a window of opportunity for when it can best be used. But that will vary from patient to patient. And I think the earlier you establish a relationship with a physician, the earlier you're monitoring your own health, the client, and then you can identify when there is a change, when there appears to be maybe high viral activity or something going on that is different from the way they've been, regardless of the CD4 count. So I think it's moved away from an automatic, at a certain CD4 count you go on antivirals, but more specific to the patient. But you need that relationship to begin early so that there's an ongoing monitoring. And since there are different views on this, you and your physician have to discuss your philosophies about treatment.
Exactly.
And
I was just
deal
going
with
to say that's, I think, the key step is to empower the patient, give the patient the information, tell them what you learned in Berlin. Okay, these are the facts, this is what we know, and you will help me, or I will help you make a decision. Is this the time to start therapy?
Some of the things that you're talking about, a lot of people aren't comfortable doing. They sort of stand in awe of the doctor. Or maybe in a busy clinic, they get such little time with the doctor that they're not comfortable in raising some of these issues, in raising some of these suggestions. And one technique that I've had success with is actually role-playing with clients, what to say, what to do, what kinds of questions to ask.
I also have experience with persons with a history of addiction. There are usually two things that happen. One is that the person often has a fear, if they're in recovery, have a fear of doing any type of drugs because they often don't have enough information, so they fear that they will become dependent upon it or that it may trigger a relapse. So some actually having some information of about what the drug does and how that drugs relate to street drugs or other drugs that they were dependent upon is really helpful. The other issue that often comes up with person with who are still active drug users is the issue of compliance. So they're often placed on antibiotic therapy, and they may take the drugs, but they're also taking it with their alcohol, with their other drugs, and often there's no discussion around what it means to take antibiotic drugs in conjunction with street drugs or alcohol, or they simply lose track of time. So the whole idea of role-playing with them, even whether they're in treatment or not in treatment, is often a helpful way of actually helping to empower them to ask the right question, but also helping them to understand what the antibiotic therapy mean in terms of their lifestyle, in terms of their fears and anxiety in relationship to where they are in their recovery.
The other thing that I sort of can't emphasize enough is how important it is for mental health professionals to have a fairly good idea of what's going on. You are much likely to hear about side effects, for instance, or new symptoms, perhaps, than the doc, and to point out to your client, you need to call the doctor today.